at the Queen Elizabeth Hospital in Birmingham, and also in the University Hospital of Manchester, both in UK. Since returning to Sri Lanka, he was first appointed to Kandy, where he established the complex device implantation program in Teaching Hospital Kandy. And later, when he was transferred to Galle, he established the cardiac arrhythmia and device implantation services in the southern province at the Teaching Hospital Karapitiya. His clinical interests are in curative radiofrequency ablation for cardiac arrhythmias, as well as device therapy for heart failure and bradyarrhythmias. He has been the editor of the Sri Lanka College of Cardiology and has also been a treasurer and a representative of the Sri Lanka College of Cardiology to the Asia Pacific Heart Rhythm Society. With that introduction, over to you, Susitha.
Thank you very much, Dr. Gurubaran, for that kind introduction. As well as I would like to thank you and the college for arranging this program, as well as this particular lecture, and giving me the opportunity to deliver it. Thank you. In the interest of time, we'll get on with the talk. I just want to know whether you all can hear me. And I see few faces, I can't see everybody, but I'm sure there are a lot of people that are known to me.
Can hear well, yes.
Okay, right, okay. So we'll get on with it. So the idea of today's lecture is to for you all to be able to be familiar with the concept of temporary pacing, pacemakers, and the concept of temporary pacing. Being the coronary care capable MOs, medical officers, I'm sure all of you are somewhat familiar, and all of you have encountered pacing, especially temporary pacing devices, and you will have handled very often. So what I'm going to talk about, probably some of you will know more than me, probably, or as good as me, and some of you will be familiar with most of it. Some of you, especially people who are new to this, may not be. So whatever it is, if you all have any unclear areas, just mark it, and then we'll discuss at the end of it. And I need to tell one thing, this is a technical area. So this is not the day-to-day stuff that we generally encounter. You all being coronary care medical officers, you all are familiar, but the general population of doctors are not really familiar at all. So it's a good thing for you all to learn and be familiar with it, because these are what we are going to talk about are life-saving procedures and life-saving devices. Right. So the objectives would be the concept of pacing and temporary pacing, to be familiar with it, and to discuss what are the indications in general, the technical considerations, and the procedural steps and the procedure details, and technical aspect of pacing. There are a number of technical concepts that you all have to be familiar. We'll try to be familiar with them in simple terms. And the monitoring, pre-procedure, intra-procedure, and post-procedure monitoring and care for these patients. So, of course, it all starts from the basics. So, you know, I know you all have had a couple of lectures where you all discussed about the bradyarrhythmias and management of them. So it makes my work quite easy. So I will not be going into in details of differential diagnosis or diagnosing specific bradyarrhythmias. But remember one thing, whatever we do with regard to cardiac rhythm, whether we are dealing with a tachyarrhythmia or bradyarrhythmia, of course, the anatomy and physiology is the key and the cornerstone of the management of these patients, or the principles based on those. So the anatomy, and therefore you all have to be familiar with basic things, the basic anatomy and physiology, as well as fluoroscopic anatomy. And whether we are talking about a permanent pacemaker system or temporary pacemaker system, the anatomy is quite similar, in the sense that practically what the anatomy you need to know would be similar. So remember, when we implant or when we set up a pacing system in a patient, we are accessing through the venous system. That would be the low pressure system. Only in rare occasions we have to access the arterial system to implant pacemakers, which you all will not be encountering. So what is cardiac pacing? Cardiac pacing is the application of an artificial electrical stimulus to the heart to produce a cardiac cycle. So I hope you all understand what it means. So basically, if someone doesn't have adequate rhythm, you all know the rhythm happens because of the electrical activation of the heart through its native conduction system. If there's no adequate rhythm, that means there's some pathology somewhere in the conduction system or a general insult affecting the normal conduction system. In such situation, what we try to do is either to reactivate that particular electrical system if we can, if not, to replace it with with an artificial system that will take over the function of the normal electrical conduction system. That's exactly what we do. So eventually the system has to deliver an electrical stimulus, which should be able to produce a cardiac contraction and therefore a cardiac output. So temporary pacing. So you all know that there are two main types of pacemakers, which either would be a permanent pacemaker system or a temporary pacemaker system. Temporary pacemakers, we generally implant in emergency situations. Of course, we occasionally use them for elective procedures. That is in anticipation of any rhythm abnormalities. At your level, what you need to be aware is that in case of acute life-threatening bradyarrhythmia, that we need to be familiar with implanting a temporary pacemaker. So this is one type of device. I'm sure you all are familiar with it. So we will discuss about this each component of the control panel that these devices have. Basically, the pacing system have two components: electrical pulse generator and the delivery system, or pacemaker. In simple terms, we call it pacemaker lead. That is the part that's going to connect the device to the myocardium. So that's another model. So these are the common models that we use in Sri Lanka. I'm sure all of you have seen it. So yeah, we'll go through. So whether it's a temporary system or permanent system, these components are the same. So it will have a pulse generator and a delivery system by way of an electrically active pacemaker lead. So these are permanent pacemakers, just for you all to get an idea. And so because these are already implanted by the time you see the patient, except those people who work in cath labs may not have seen probably the permanent pacemakers. So what is the relevance of this to what we are talking about today? Of course, these devices also can do pacing, but not to the same efficiency as the specific pacemakers we discussed, but may be good enough to save a life. So again, you all need to be familiar and confident of using them for the purpose of pacing. So it could be the temporary pacing we may be using in situations where a patient has a life-threatening bradyarrhythmia, which may be even reversible, but reversing of that particular pathology that causes bradyarrhythmia might take time. So you need to buy time to correct the problem. So that's when you will have to use a temporary pacemaker till the patient regain the own rhythm. It may be electrolyte imbalance. It could be a drug overdose or poisoning, maybe Caneru or yellow oleander or any other cardiac toxic agent. Likewise. So in certain other situations, we use temporary pacing. The people who work in the EP units will know, like in case of during elective cardioversions, even we sometimes implant temporary pacemakers, since we anticipate either a significant bradyarrhythmia or even asystole immediately after cardioversion, considering each patient's factors. As well as in certain surgical procedures, could be cardiothoracic, or even in other surgical procedures, if patient has underlying tendency for bradyarrhythmia or risk factors of bradyarrhythmia, we might consider it. And of course, as bridging to a permanent pacemaker. So talking about the temporary pacemakers, there are three main types. The commonest one that you all know are the transvenous pacing. But also remember, that's what is called transcutaneous pacing. We'll discuss it, as well as epicardial pacing. So transcutaneous pacing is when when you all use the defibrillator pads or patches and then deliver the electrical stimulus. Transvenous pacing we will be discussing, and epicardial pacing especially happens in cardiothoracic theaters. So for us to know, to understand the importance of temporary pacing as well as to be familiar with the concepts of pacing, you all need to understand that not all arrhythmias we treat similarly. Not all bradyarrhythmias we treat in the same way. So some bradyarrhythmias we might not even worry too much. By correcting certain simple things, you might be able to improve it, like electrolytes or drug effects, likewise. But certain arrhythmias, certain bradyarrhythmias, you may not have much of a time before patient go into a cardiac arrest. In such situations, you have to be very proactive and do what is needed to simultaneously to do certain things to maintain the rhythm, as well as simultaneously do things to correct the underlying problem. Why arrhythmias are high risk, as well as why certain arrhythmias we call them high risk, because they are very unpredictable in certain situations. And the nature of the arrhythmia can be very dynamic. Certain stable arrhythmia can degenerate into a very unstable arrhythmia within a matter of seconds. So therefore, you have to have an idea to identify what are the high-risk arrhythmias, high-risk bradyarrhythmias, and then take certain precautionary measures and be proactive in managing those patients. So to name few, high risk, we can classify certain arrhythmias as high risk, and I'm sure you are all are familiar with these. Of course, if someone has asystole, obviously there's no rhythm. That means it's obviously a cardiac arrest situation. And same way, a pulseless electrical activity, something very, very challenging to diagnose as well as manage, because sometimes you might even see a reasonable electrical activity, but there's no pulse. So absolutely no cardiac output. So you have to be very careful in identifying that type of patient and managing. And then various degrees of AV blocks or various degrees of sinus nodal pathologies or sinus nodal, we can even call it sinus nodal blocks. And then sometimes you might talk about, you might talk about managing a bradyarrhythmia in a patient who really doesn't have any bradyarrhythmia. That's in situations where we see patient has features of the conduction system pathology, like a trifascicular block, where patient's conduction through the electrical system shows signs of delay. But if you count the pulse of such patient, there's absolutely no bradyarrhythmia. But we might worry more about that type of patient in certain situations than someone who's already having a bradyarrhythmia, like a sinus bradyarrhythmia, sinus bradycardia, or even bradycardia secondary to AV nodal pathology. I'll tell you the reason a little later. So sometimes, actually I mentioned it earlier also, because that type of patients might behave more unpredictably than the patients who already have a organized bradyarrhythmia. So, and in such situations, you have to be proactive in managing such patients. So, of course, basics are always important, like ABCD approach to patient, identifying how stable or unstable the patient, and reassessing the patient again and again to see whether the patient is deteriorating or not, and stick into the clinical sense to understand what is the best thing to do for a given patient. So just to recap, I'm sure this was discussed, just to recap few examples of high-risk bradyarrhythmias that you all encounter in CCUKI on day-to-day practice. If you all can quickly answer, that's okay. Otherwise, I'll tell the diagnosis. But just refresh your memories that this is the type of bradyarrhythmia we don't want to take chances. So you can obviously see there's more than one problem here. So there's significant ST elevation, especially involving inferior leads as well as lateral leads. And then, of course, the rhythm doesn't look right? So the rhythm is not normal, and it's not a sinus rhythm. And if you see a little more carefully, obviously you see a bradyarrhythmia here, bradycardia, regular bradycardia, and then you see there's no association or synchrony between the atrial activation causing P waves and the QRS complexes. So there's a AV dissociation. So with this combination, you don't want to take a chance because this is an evolving situation. Someone is having a STEMI, ST elevation MI, and then you already see the result or the damage done by the STEMI. It has already affected, or the ischemia has already affected the AV nodal conduction. So fortunately, this patient's maintaining the rhythm because there's what is called an escape rhythm. So, but we don't know. The escape rhythm comes from some another area in the myocardium. It's obviously an escape rhythm doesn't come from the conduction system. It's somewhere else in the myocardium. That happens because the conduction system has got damage. So it may be a matter of time before the area that is currently working as an escape rhythm can also get affected due to extending ischemia. So in such situation, we can't just rely on this type of escape rhythm. So we have to have clinical sense to understand what's happening. And then, can anyone say what's going on here? So are we looking at a bradyarrhythmia or a tachyarrhythmia? So if you see, it's a bit confusing, but of course it has both. It has a tachyarrhythmia as well as a bradyarrhythmia. So another important concept for you all to understand is, in a certain patient, sometimes you might see more than one arrhythmia. So you might see one arrhythmia in one chamber, another arrhythmia in another chamber. Since there are 4 chambers, you might actually even see 4 different rhythms in 4 different chambers. That's all possible. And Dr. Gruber might even say, actually, you can see more than one rhythm in one chamber, even in one chamber. So that even can happen because all these are related to microcircuits and re-entry circuits inside the heart. It's cardiac muscle. Myocardium is a highly active, electrically active tissue. So here, what we are saying is that in the atrium, you see a fast rhythm, which is a fast, regular, very fast, regular tachycardia, almost going at a rate of 300. So it's atrial flutter happening there. But of course, if you see carefully, you don't really see that many QRS complexes. Actually, for the whole strip, you see probably 3 QRS complexes. And then you are seeing the electrical artifact caused by the ECG machine. Other than that, there's nothing. So this type of patient, again, you can't take too much of chances. Because we don't know, even these few ventricular activations we are seeing now might not happen within a short time. So therefore, be familiar with identifying when to worry and when you can observe to see whether patient is stable or not. Another type of bradyarrhythmia, I wouldn't say this is very high risk, but it can behave unpredictably. Therefore, you have to be careful. You all know this from medical student days. This is a 2nd degree AV block, Mobitz. Which type is it? Good, very good. Yeah, so it's Mobitz type 1. And at the same time, you might see without that type of a progressive delay in the AV conduction, you might just see a fixed AV nodal delay and then a sudden drop of phase. And out of the two, this is more unpredictable than the previous ones. Again, this is a relatively higher degree of AV block. And here, of course, we talk about bradyarrhythmias, but we are not seeing any bradycardia. This is what I mentioned earlier. So you all can see that there's no bradycardia. But this is if this particular patient has other indicators like recurrent syncope or loss of consciousness or unexplained seizures, or if the patient's LV functions reduced, then this is not a rhythm that you can actually ignore. So this is, of course, a sinus rhythm, yes, because the rhythm starts from the sinus node. It has somehow managed to go through the normal conduction system and has activated the ventricle. But then you see there are delays in all conduction areas, like from SC node to AV node. The PR interval is delayed. And once it has gone through the AV node, activating the ventricle is delayed. That's why you are seeing a bundle branch block appearance. So you are seeing right bundle branch block appearance. And if you see carefully, cardiac axis is also not normal. So these are features where the conduction system beyond what we know, like right bundle, what we talk commonly, right bundle, left bundle, beyond that also the conduction system is pathological. So up to the Purkinje level. So in these situations, we can't rely on that conduction system because it can give way any moment. Another situation where you see very significant bradyarrhythmia as well, which is showing features of SA nodal damage as well as A nodal damage, probably following a ischemic event. So in these situations, again, you can't really take chances. Then we encounter bad situations like this. So you don't see really any organized activity. You see just flat lines. What are we going to do? Could anyone tell the possibilities here? I'll try to get few of you to talk because I know otherwise within another 10-15 minutes, I might lose all of your attention. So yeah. You can unmute, few of you, doesn't matter. Whoever who want to quickly answer. Oh, of course, actually, so you all are not supposed to read what is there. Just tell what you see. Is this a bradyarrhythmia? Obviously, you don't see complexes, right? So yeah, the learning point here is, so of course, the top panel, there are four irregular lines. They are all ventricular fibrillation, right? You can see what is on the right lower row. It's almost like asystole, but it is not asystole. It's fine VF. In such situations, even if you implant a temporary pacemaker, it will not work. What we have to do is defibrillation. So just because you see a flat line, always don't assume that you are dealing with a asystole. So the point there is, if you're not sure, always get expert opinion. Always ask someone else. Always ask someone else. And you might get another aspect of what you are dealing with. So then stick to protocols. So if you are dealing with a severe bradyarrhythmia, first thing would be to activate the basic life support and advanced life support algorithms. And in cases where there's no cardiac output, start CPR, you know all that. And especially for bradyarrhythmia, there are algorithms in the advanced life support protocols. So be familiar with them. There's not much of a change over time, but there are later versions. So you all can refer one of the later versions even. So you all need to be familiar and you all know. Then there's in certain categories of patients, there's no other choice than going for temporary pacing. So we'll come to that. So I mentioned that while we commonly talk about transvenous pacemakers, all of you can be familiar with some kind of pacing using the defibrillator because that's the easiest, most accessible device for you all, for any of us when working in the CCU. Activating a cath lab and getting a time and implanting a temporary pacemaker always can take some time. This type of device could bridge the time gap to enable the patient to live till the patient get a proper pacemaker system. So you all need to be familiar with the few knobs there and identify what controls the rate, what controls the current output, and how to synchronize and start the pacing activity. So the most of these models have transcutaneous pacing, and we can use it would be most effective if you use the adhesive pads or the attachable pads that we have generally these days in most of the CCUs. So positioning is important. You can either use the anterior to posterior approach or anterior to anterior approach, like when you are defibrillating a patient, and it needs to be firmly attached using the proper techniques. And then you will need to be familiar. Obviously, each of these machines have a manual, and it clearly gives the guidance how to switch on the pacing activity. So be familiar with it. And sometimes actually this is good enough to save a life. And we often see, especially when a patient being transferred or when the patient is in the ETU, these machines have helped saving lives. So the main focus for us today would be the transvenous pacing. So what do we do during this procedure? We use an introducer sheath or introducer kit to get access to the venous system of the circulation, and then place electrically active lead, we call it lead or wire, to enter the heart through a certain route, could be through femoral vein or through internal jugular or subclavian. But generally, we try to avoid as much as possible the subclavian as well as internal jugular approaches for various reasons. And femoral would be the easiest. And as coronary care medical officers, it's very important for you all to have vascular access techniques, be familiar with vascular access techniques and develop the skills. And any of you who are interested, you all can always join our list and then be familiar. And it's a very important basic skill to be able to access either central veins, either femoral or internal jugular. And then you all need to be familiar, not very much, but at least in simple terms, be familiar with the various fluoroscopic views we use in the cath lab to position these devices or the wires in the appropriate areas in the heart. Some of you would be already familiar with this. So we use about 3 projections, especially in this procedure, what is called right anterior oblique projection, left anterior oblique projection, and the AP or anterior posterior projection. So remember, our heart is positioned in the body in an oblique way. It's not the diagram that we generally draw that you see inside the body, and therefore it makes things complicated for us to interpret the fluoroscopic anatomy, and that's why it's important to be familiar. And always remember, it's even more difficult because always there's going to be some anatomical variation. So just by looking at a diagram, you can't generally learn that. You need to keep looking at the procedures, keep looking at procedures being done, keep looking at procedures that have been done. If you access the fluoroscopic system and the databases, you can see how variable sometimes the anatomy can be. So this is a typical positioning of a temporary pacing wire in the right ventricle of the heart. That's the chamber that we use in cases of emergencies to activate or reactivate the cardiac cycle. So this is the same wire or the lead that we are looking at from a different angle to verify that it is actually where it need to be that we are seeing. Remember, these fluoroscopic views are 2-dimensional, but we are talking about a 3-dimensional anatomy in the cardiac chambers. Because of that, you have to look at more than one fluoroscopic view. Yeah, discuss it. And then I mentioned that in cardiothoracic theaters, you all may not have seen many. We use transcutaneous epicardial pacing systems, where the surgeons, before they close, they fix these small wires into the epicardial side of the heart, and then taken through the skin, they can be connected to the pacing devices. The same generators that we use for transvenous pacing, we can use for these. Epicardial pacing, remember, won't be as reliable as transvenous pacing. The epicardial, the conduction system of the heart is in the endocardial side of the heart. Therefore, however much we try to pace from epicardium, those pacing systems are not really that effective because there's a significant thickness of myocardium between the pacing system and the endocardial conduction system. Getting back to our main focus, which is the transvenous pacing system. So this is a common model we use in Sri Lanka for temporary pacemaker generator, and this is called pulse generator or pacemaker generator, and there are at least 3 to 4 regulators that you all need to be familiar with. So it's important to be very familiar with it till and not to use it till you are very familiar and confident about it, because sometimes without knowing, if you do something, and it can actually kill the patient then and there. For example, like inappropriately adjusting the sensing button or the output button so that it stop capturing means patient will not have any cardiac output. Patient can immediately go into a cardiac arrest. But of course, it's not a very difficult thing. So the best would be for you all to be very familiar with it. So one regulator for to control the rate, another regulator to control the current output. We will discuss a little more about it. And then another regulator, what is called sensing control button, to change how much of cardiac electrical activity can this generator see. So we can change that. And based on these, and also you will see a knob to change the mode of the pacemaker. So what are these concepts we'll discuss. So as I mentioned, so this close-up view of the same, and you can see, and when you are dealing with patients with having this, have a look at it, and then observe when someone adjusts it and see what's the response the patient get or the ECG on the monitor get when you're adjusting that. And this is the other component, which is the temporary pacemaker lead and the adapter wires that connects the lead into the pulse generator. There are different models. Don't worry too much about them. Generally, we will have compatible generator to a compatible pacemaker lead by way of an adapter specifically made for that particular combination. But occasionally, you might encounter in the cath lab a generator of one type, pacemaker lead of another type, or temporary pacing wire of a different type without the proper connection. That's a very bad situation to be if you don't have the right adapter. Even after you take the trouble to implant the temporary pacing wire in the heart, and if you can't connect it, you can't deliver any current. So before you start accessing even, make sure you have the right system, compatible system at hand. Generally they are there, but people need to be cautious about it. So that's how the connectors. So there's a positive terminal as well as a negative terminal. And the red color one goes to the positive terminal. The black color one would go to the negative terminal. So there are, if you need, depending on the situation, depending on how the patient is positioned, sometimes you can extend the length of it by using connecting cables. Then more important part would be to understand what happens once you fix this device and adjust the parameters, and patient is supposed to get a rhythm. If the patient doesn't have a significant rhythm, then you can adjust the parameters to achieve a rhythm that we want the patient to have. So either looking at the monitor, or more usefully, if you look at ECG, a rhythm strip or a 12-lead ECG, you will see certain things like spikes, and then a QRS complex, which is not necessarily similar to what you would see in a normal patient. And yeah, likewise. So depending on how many pacing wires we are using, you might see more than one spike, but don't worry too much, because in emergency situations, we only want to pace the ventricle, because to maintain a cardiac output, pacing ventricle is more than enough. And then there's the concept of pacing versus capture. I'm sure the EP people will know, but so it's a concept that you need to understand. So just because we place a pacing system in a patient, and just because we switch on the device, doesn't necessarily mean the patient's heart going to start beating. So there are a few other factors that need to be met. We need to deliver the appropriate level of current we need to make sure that particular current is capable of activating the myocardium, and that myocardium goes into effective myocardial contraction, and that is that combination of these things called myocardial capture. So remember, pacing and capture are two different things. A pacemaker can pace, but it may not be captured in the heart. The same way, now I'm delivering a lecture, I'm delivering the talk. Some of you are listening, but some of you may not be, all of you may be listening, but only some of you may be paying attention. Some of you may be thinking about when to have your dinner. So that means I have not captured you, though I am pacing. That's the concept, remember that. And so, yeah. So basically, so if you look at these two rhythm streams at the bottom, you can see you have a flat line, and then there you can see the spikes. But then there's no QRS complex. That's where the pacemaker has pace, but there's no capture. And on the bottom line, you can see there you can see pacing spikes as well as a QRS. So the QRS complex happens because the pacemaker has successfully activated the myocardium. And remember that doesn't only depend on where we keep the temporary pacemaker wire in the heart or how much of a current we use. It also depends on a lot of other factors of physiology, like electrolyte status of the patient, metabolic status of the patient, the pH of the patient, and so many other things. So we can't just assume that everything is fine and the pacemaker to work. So if it's not working, while you are adjusting parameters, also think what else to do to optimize the situation. So something again, close-up view of the same. So you can see here the pacing spikes. You can also see atrial activity. The atrial activity has nothing to do with the pacemaker, because in this situation, the pacemaker spike is happening in the ventricle. And you are also seeing QRS complexes in this strip, but you can see that QRS complexes are not immediately preceded by a pacing spike. So basically that means the pacemaker has, the rhythm is coming from somewhere else. That is the patient's escape rhythm. Fortunately, there had been an escape rhythm, and the pacemaker, for some reason, is delivering current, but it's not capturing the myocardium. So this is a very important concept for you all to be familiar with, and there are ways of adjusting it and correcting it, and therefore be familiar with to identify. And then there's another way of identifying whether the pacemaker is capturing the heart. So remember, since we are pacing the right ventricle, the right ventricle is the chamber that's going to activate first in that cardiac cycle, not like in a sinus rhythm or not like in any other rhythm where a different chamber is activating. So in a paced rhythm, we are going to see basically the cardiac cycle starts from the right ventricle. Therefore, the right ventricle is the earliest activating chamber, and then the impulses spreads to the left ventricle. So there's a delay from right ventricle to left ventricle. It's essentially like someone having a left bundle branch block. So you all are familiar with a left bundle branch block pattern. So it's not a true left bundle branch block we are talking about. So if you recall a ECG with a left bundle branch block pattern, that's the type of pattern you are going to see in a patient whose right ventricle is being paced. Simply because, not because the patient has a left bundle branch problem, but patient has a mechanism to activate the right ventricle first. So it's almost the same thing still. So therefore, if you see that pattern, that means then it's a useful clue that the pacemaker is capturing well. But make sure that the particular lead is in the right ventricle, which is 99.9% of the time it will be right ventricle, but again, be careful about it. And then few other concepts like pacing. So we mentioned what is pacing, to deliver an electrical impulse to capture the heart. And at the same time, the other important concept to be familiar with is, very important to be familiar with, is what is called sensing. So these devices, while they deliver electrical stimulus to activate the heart, they should also be able to see what's happening inside the heart. For example, if someone who has a bradycardia, severe bradycardia at the beginning, in a couple of hours' time, if the patient is going to regain the rhythm, the pacemaker should be able to know that. If not, what happens? Because we all are not all the time staying with the patient. If not, what happens is the patient own rhythm will happen. At the same time, the pacemaker will also try to activate the heart by delivering stimuli the way we have asked it to do. That will result in unnecessary electrical activation, and actually it can trigger even life-threatening arrhythmias. So to avoid that happening, there's a way, there's a mechanism whereby the pulse generator can also see what happens. And then it will decide whether it need to deliver the current or whether it need to just stay without doing anything. So that's capability is called sensing. We have the option of either keeping the capability, or if we feel it's not needed. For example, if someone is in complete asystole or in complete heart block without any rhythm in the ventricle, then of course we don't need to worry too much about it. Then of course you can put the sensing into an off mode. So the pacing spike we discuss what it is, and the capture also we discuss. Pacing threshold is a concept where we try to understand how much of what would be the minimum current that we need to deliver to the patient to capture the heart. So that also means any current above that level will pace the heart. But we like to know what is the minimum current. The reason is we don't want to waste the battery of these pacemakers. For example, if it's a temporary pacemaker system, that's okay. You can replace the battery. But in case of permanent pacemakers, you have to be very careful with the battery life. So in these situations, it's good to know what is the threshold, and then we decide where to keep the output level. So depending, of course, we are not going to keep at the same level like the minimum current level. We will keep a safety margin and keep it like that. So it's not only to save the battery that this concept is important. We also will have an idea how safe the patient's pacing system is. So for example, with certain changes in the internal homeostasis of the patient, like the electrolytes and the pH and all other things, oxygenation and all that, these things can change. Electrical activation also can change. And we don't want to keep the output at a level where it can easily get affected with it. So we always keep a safety margin and keep at a higher level. So remember the concept of pacing threshold. So there's a way of checking it, and it's a bedside test that you can do using the generator, but of course you will need to be very familiar with the generator and pacing activity before doing it. And that I mentioned that there's a button that is responsible for changing the modes of the pacemaker. So the two most important modes you all want to know is the synchronous, or what is called on-demand pacing, or asynchronous or fixed rate pacing. So remember I mentioned about what is the concept of sensing. When a pacemaker is capable of sensing what's happening inside the heart, that's the on-demand mode. So there the patient's pacemaker can wait and only pace when there's actually significant bradyarrhythmia. It can change what is it's doing from beat to beat even. So it might pace on a certain beat, and then few milliseconds later it might not pace, because if a patient get a reasonable cardiac activation. In asynchronous pacing, we keep the sensing option off, so the pacemaker can only deliver current output on a given time scale or at a given rate. So this is how you would do a stimulation threshold test. So you can see, if you look at, don't worry too much about text, just look at the ECG strip at the bottom. So it says the current is higher initially. So the person is reducing the current appropriately gradually, and you can see the initial stretch, there's a pacing spike followed by QRS curve flex or some kind of ventricular activation. And after a certain point, you start seeing spikes without any ventricular activation. And you can occasionally see the ventricular activation, but that is not corresponding with any stimuli. So this is a situation where you have identified the threshold to be in that area around 1 milliamp, just above the 1 milliampere level. So that's a threshold testing. Actually, this need to be, sorry, there's a small mistake. This need to be millivolts actually. And sensing, as I mentioned, is generator's capability of seeing what's happening there. And that, again, will need to, the pacemaker need to be able to see what's happening and then decide whether to not do anything or to deliver current output. So this diagram tells you what exactly sensitivity means. So sensing is the capability. Sensitivity is a level that we decide for the pacemaker. So it's like a window. So if we tell the generator, if we program the generator in a way that it can see any electrical activity above certain level, then it can see everything above that. But then it might also see unnecessary electrical activation. So remember, apart from the myocardium, there are other electrical active structures in the body as well, in the thorax as well. And there can be electrical noise coming from outside environment. So you have to decide the appropriate range to decide on the exact or the ideal sensing level for a particular patient. And this can actually change from patient to patient. Again, can change depending on the environment and other factors. But as a matter of fact, the standard pacemakers generally do well if you keep the sensing levels generally around 2 millivolts in the ventricle. In the atrium, it will be different, but it doesn't matter for you. In the ventricle, it should be around 2 millivolts or above. Generally, the ventricle activation will cause a current which goes beyond that level. So the pacemaker can generally see an effective cardiac cycle at that level. So this is what happens if there's no proper sensing, or if there's a problem with sensing. So in the first strip, you see the pacemaker is working appropriately in the first 3 beats. Why you do say you see a pacing spike followed by QRS activity, and then subsequently you don't see that pacing activity. Instead, you see a very nice P wave followed by QRS. That sequence, PQRS sequence, is happening. So here, patient's own rhythm has started, and pacemaker has immediately ceased to deliver the current to avoid any unnecessary arrhythmia happening. In the second strip, what you see is, you see pacing spikes. You also see some PQRS activity. Of course, there's no coordination, and this is what happens. On this red circle, you see the patient on QRS happened, and on top of the T wave, the pacemaker delivered the current output, and that's not good. It resulted in what is called R1T phenomena, and therefore a VF. So these things happen. So be careful with sometimes it may not be a major thing, but I mean, just a matter of adjusting that sensing button. But this is what happens if it is not appropriate. So then, because pacemakers are somewhat complex, since not everybody who's handling the patient, taking care of the patient, are familiar with these concepts, there's a simplified way of identifying a particular pacemaker. So we use these terms in our day-to-day practice. So be familiar with some of it. So the commonest pacemaker that we use is what is called VVI, where the chamber that we are pacing is the ventricle. The chamber we are sensing is also the ventricle. And when the pacemaker sees an adequate cardiac event, it will get inhibited. So that's what VVI means. So when I say ventricle, it's the right ventricle in cases of temporary pacing. So this is again the nomenclature in more detail, but you all don't need to bother too much about it. But at least understand that these 3 first letters are important to identify what exactly does this pacemaker do. So you might see either V or A as the first letter. You might see either V or A or D as the second letter, likewise. So we discussed this already, both. Yeah, here what happens is, can someone say, the actual answer is there. So yeah, so here what happens is the patient has adequate rhythm, and at the same time, the pacemaker is also competing with the rhythm and trying to pace. This is because we have used an inappropriate pacing mode here. While patient has intrinsic activity, pacemaker is also trying to pace because the pacemaker can't see what's happening. So here the sensing activity is being taken out. So the pacemaker is in a asynchronous mode. So that's why asynchronous mode can be dangerous in some situations. Here what happens is the pacemaker, the patient doesn't have underlying rhythm in this stretch, and the pacemaker also has not fired or activated. And you can't even see a pacing spike at a certain period. So here there's no capture, no pacing also, and no intrinsic activity. So that's a situation where you have to urgently adjust the parameters so that the pacemaker can regain capturing. Another example where you see a spike followed by QRS in the first two beats, and then you see a spike, but you don't see any electrical activity. So that means there's a failure to capture there. And the next beat you see is a native beat. So patient fortunately has some activity. But then again, you see the pacemaker is again trying to pace in an inappropriate situation, or in an appropriate level. So we talked about what happens if you keep the pacemaker on and then the patient has a reasonable rhythm, and if the pacemaker can't see it, or if the pacemaker can't sense the event, this can happen, what is called competition between the two. So these are a few concepts that almost every day you need to be able to, if you are to identify what happens with the pacemaker, you all should be able to be familiar with it. So yeah, the slides will be shared, and so try to go through it again, then you will understand. So remember, so it's quite normal that initially you get confused because quite a lot of technical concepts here. But when you try to understand, it's very logical. So it's not like remembering certain antibiotic combination for certain microbiological organism, something like that. It's just you need to memorize. But here there's a logic behind, so you can understand. Yeah. So that's about implantation as well as technically handling a pacemaker system to get an adequate cardiac activation. But equally important would be what you do when a patient already has a temporary pacemaker. Is it all done there? Certainly not, because that's when another new set of problems can happen. For example, we are fixing a device externally, but connecting it to the myocardium. So a device, part of which is externally fixed, but the rest of it is in an indwelling, which is in an indwelling system and is actually ending up in the heart. So that's a very good track for any infections to happen, or it can give easy access to for any bacteria to enter the myocardium. So this is a high risk situation for endocarditis or sepsis. So be careful with that. So the procedure need to be done completely sterile environment with highly sterile techniques, and post-procedure care also need to be completely similar, where you maintain high degree of sterility and make sure there's no soiling, and change the dressings if necessary, whenever necessary. And as long as the temporary pacing system is in the patient, attached to the patient should be on appropriate antibiotics. Otherwise, there can be worse things happening. At the same time, remember this is an invasive procedure, and some of the patients we are dealing with are generally elderly or very frail patients, and it's not that difficult to perforate the heart, even with the tiny temporary pacemaker wire. Temporary pacemaker sizes, there are different sizes, and especially if you use a relatively large French gauge wire, then it's very easy. I mean, without we knowing, it can pierce through the myocardium somewhere. It could be in the atrium or ventricle. Even if we are placing the temporary wire in the ventricle, before that we are going to manipulate it in the atrium as well. The atrium has a very thin tissue, so it can pierce or rupture any part of the myocardium. So what is important is monitor hemodynamics throughout and identify any early deterioration, because this is a situation where if you act promptly and quickly, you can save the patient. You can just drain it out if there's a temporary situation. So patient will not go into a cardiac arrest. And one other thing we practically see is we take so much of trouble and implant a pacemaker, temporary pacing system in the middle of the night. For a patient who doesn't have any underlying rhythm, complete heart block or almost asystole or complete heart block. So patients start feeling better, pacemaker start pacing nicely. You send the patient back to the CCU. The first thing patient will do is sit and try to drink something, tea or something. And that can be fatal. That particular one moment where the patient sit can actually dislodge the temporary wire from the right ventricle. So if the wire dislodged through the tricuspid valve and comes out to the right atrium, it's not going to help the patient. Patient can collapse then and there. So it's equally important to implanting it is looking after that. And of course, you all know that our patients are not very careful on these things and they won't listen. And you need to keep reminding the nursing staff and other staff and the patient that positioning, movement, transfer, all that need to be very careful. So if a patient who's fixed to a temporary pacemaker need to be transferred for example, for a ultrasound scan or CT scan, there's a certain way of handling. You have to make sure that patient is handled that way, because we have seen so many occasions that this type of things have happened, unfortunately. So these are the basic things. And so monitoring, as I mentioned, one other important thing is the pericardial efficiency in these procedures, either whether it's a temporary pacemaker or whether it's even any other cardiac intervention, might not happen immediately after the procedure. It might happen maybe a few hours later, maybe even more than a few hours later. So it depends on how rapidly or how rapidly it get accumulated. And therefore, you need to continue to monitor even beyond initial few hours. I think we have almost come to the end. Anyway, 1 hour. Yeah, I'm happy to answer if you all have any questions. Okay.
There was one about epicardial pacing wires, when to remove, method of removal. Is it enough to cut short the pacing wires?
Okay, the first question I can see is about whether we can use overriding pacing. Is it the first question? Or?
I think there is a question at 9:12, which was, I think, put during this lecture. It says epicardial pacing wires, when to remove, method of removal, and is it enough to cut short the pacing wires?
Yeah, okay. Okay, yeah, I think it's a very good question. So someone who has been handling post-surgical patients. When to remove, of course, depends on, it's like the indication of umbrella, when the rain stops, you remove it. The same theory, you take it out. So basically, if you would have implanted this because either the patient already had a bradyarrhythmia or the surgeon anticipated the bradyarrhythmia during the postoperative period. For example, in cases of aortic valve replacement, they handle very close to the AV nodal area during surgery. And in certain occasions, the patient goes into complete heart block. And that's the one common situation where epicardial pacing is needed. Or in certain CABGs or other valvular surgeries, it can be necessary. If the patient's that particular pathology or the rhythm improves in next few days, and it shows signs of further improvement, like we can gather clues through the ECGs, serial ECGs, to see whether the patient is in an improving direction in terms of the rhythm, or whether the patient's rhythm seems to be improving. If the patient has convincing evidence of improvement, you can decide to remove it, no problem. And of course, you should not remove it just on the day of discharge. We want to monitor the patient at least for a couple of days after removing. So if the patient has a reasonable rhythm and shows signs of improvement, you can. On the other hand, if the patient doesn't show any signs of improvement, of course, no choice, but we have to go for a permanent system. So in that case, you keep the epicardial system till the permanent pacemaker is done. And after the permanent pacemaker, you can remove it. And so you decide timing depending on patient clinical status. And method of removal, most of these wires are designed to be able to just take out completely when you pull it. But if you feel it is stuck hard, you can cut it, no problem, no harm. But if you are cutting it, you need to obviously it's best to talk with the surgical team, because one thing we have seen occasionally is certain wires that could have been taken out. If you intentionally leave them, they can cause minor problems in subsequent times. So it's best if you can take it out. If not, it's okay. Part component of it can leave. Even when you pull, there's no guarantee the whole thing can come out. Sometimes it can. Obviously, you don't need to reopen to remove this. They're meant to be taken out like that. I hope I have answered the question. Is there anything else you want to know about that, or shall we move to the next question? So the next question is about overriding pacing. Okay, so basically the question is about when can we use override pacing. So that's a good question. Obviously, as the term says, overriding means there has to be another rhythm to override. So that means patient is in tachyarrhythmia. So sometimes you can, so for example, if the patient is in SVT or a VT, this can only be done in hemodynamically stable rhythms. If the patient is hemodynamically unstable with tachycardia, of course, you can't do overdrive pacing. It's actually, the actual term is overdrive pacing. If the patient is hemodynamically stable, you can try it. So what you do is, you look at the rate of the tachyarrhythmia and then go at a higher rate than that to a certain period. Like, you don't keep going on for hours like that, but for few seconds or maybe 1 minute or so, focusing on taking over the electrical activation of the heart. And that works quite often. Only thing is, it has two sides. Very often you will get rid of the tachyarrhythmia, but there's a small chance you might actually deteriorate the arrhythmia to a different one. So if that happens, for example, if there's a VT, stable VT with hemodynamic stability, when you start overdrive pacing, rarely it can degenerate into a VF. So what you need to do is, you need to be ready to defibrillate if that happens. Basically, you should do it only when you have backup facility, you have expert help, and you know what to do in case if it goes wrong. So that's, otherwise you can do it, yes. And there's a second component to that question. Is it necessary to give antibiotics following insertion? Of course, it is necessary, especially in our Sri Lankan setup. In certain Western countries, they use alternative approaches like inserting the temporary system through the neck using a permanent device rather than the big generator that we use for temporary devices. They easily use a permanent pacemaker and a permanent pacemaker lead, but keeping it as an external system till the full internal system is done. For them, it's not a problem. They have finances for that. But in Sri Lankan setup, we can't use. So since we are using the standard conventional temporary pacing systems, and because we go through the groin axis, there's a very high risk of infections. Even if you use a different axis, it's not going to change. You will have to use it. We have seen occasionally when even inadvertently antibiotics were not used, certain patients have got very complicated endocarditis situations. So yeah, so that's a must. That's for temporary pacing. But for permanent pacing, of course, antibiotic use is minimum. And then how can we adjust the output button comparing to sense button? Yeah. So basically, output is a relatively easy concept. So for you all, what you need to understand is, whatever the button my first instruction would be, whatever the button you are going to change it or adjust it only if you know what you're doing. And to make sure when you are doing that, you are looking at the monitor. More importantly, you are palpating the pulse of the patient. While doing that, you can do. So if you start losing pulse, just stop what you're doing and reverse what you did. So don't rely on the monitor only always, because monitor sometimes can mislead you. Sometimes the monitor can detect the electrical spike of the pacemaker, and you might actually be mistaken it for a QRS complex. So most important thing is, eventually what we want is the patient to have a cardiac output. So keep palpating the pulse while you adjust these buttons. So output button, of course, you need to adjust it if the patient doesn't have adequate pacing. For example, if you keep seeing that some of the spikes doesn't have a QRS complex, so while the pacemaker is going on, if the pacemaker doesn't give QRS complexes for every pacing spike, you can increase the output and see whether it sort out the problem. But beyond that, it's better not to experiment too much till you are familiar with it. And for the sensing, generally in your situation, there's no requirement to change the sensing button. Generally, we keep it at, I told you, for the right ventricle, the appropriate sensing level is between 2 to 3 millivolts. And if you keep it around that level, then it's going to remain, it's going to be functioning adequately. For atrium or left ventricle, it's different, but for right ventricle, that's adequate. So actually, it's not necessary to change the sensing for your work. So any other questions?
Sir, one of our patients got muscle twitching when we attach to external pacing. How can we avoid it, sir?
Okay. Yeah, so muscle twitching, you must be meaning muscle twitching. Which area of the body was it?
Chest wall, sir.
Is it on the left side or the right side?
Right side, sir.
Okay. So basically the commonest thing that happens is if the pacing system start capturing the nearby nerves, the two most important nerves are the phrenic nerves on the left side and the right side. So, and remember this, some patients have anatomical variations. The phrenic nerve, generally the phrenic nerve on the right side goes very close to the right atrium and slightly away from the right ventricle. But if we deliver adequate current output, it can even if the phrenic nerve is not too close to that pacemaker lead, it can get captured. So when the phrenic nerve gets stimulated, the diaphragm start moving. And then that whole region can start moving. That's a common thing that happens during permanent pacing even. So we do certain things to avoid that happening. Same way on the left side, it can happen. So that's one possibility. The same way, there can be other muscle groups like intercostal muscles or even certain abdominal muscle groups that can get contracted due to electrical impulses that get dispersed through the pacemaker lead, because there are small nerves crossing each area. So very likely that the other possibilities, these electrical systems are supposed to be completely insulated. So when we fix the pacemaker lead to the generator, whatever the current that generator delivers will be flowing through the pacemaker lead system into the myocardium. And we don't expect it to leak, but there can be occasionally small leaks happening, maybe due to insulation break and so on. And that can actually capture unnecessary structures, and that can lead to that type of things. It's a good question. Good.
Thank you.